it snuck up on me, the time it did. But no, I am excited about this topic just because it's been a hot topic this year. And
Yeah,
it's,
absolutely.
I know the year is like gonna be over in 2 seconds. All right. Where did Brian go?
I'm here. I just stopped share.
Okay. Okay.
You want me to stay on video while you do all your housekeeping, or do you want me to come back on?
Yeah. You can
Okay.
stick around. And it's totally up to you. I'm joking. So, good evening, everyone who is popping on. It's good to see you guys on a Monday night. The sun is still up though, so still summer, which is good news.
So tonight we've got a special guest from Medi USA, Brian Grolo. He's on with us, and SureFit is going to be here on hand to answer any questions about their related products. If you've been with us before, we are live, of course, and we're going to answer questions at the end. But while you're online with us, if you have questions, go ahead and type them into the question and answer box at the bottom of your screen. That way you don't forget them and we don't lose track of them. And then if you have any like technical issues or anything like that, go ahead and put those in the chat and we'll do our best to get those taken care of for you.
And we obviously always like emojis, so you can see I'm doing some high fives and some thumbs ups. Thumbs ups, thumbs up.
Yeah,
So
so
if you've got
Zoom
anything
webinar,
that you love, just let us know.
Zoom webinar gives us the option to interact with these reactions. If you just send us some reactions throughout the presentation, that lets us know that you're still there and that you're listening and enjoying what is being discussed.
Right. And before you guys logged on, I was just mentioning 8 o'clock snuck up on me. I wasn't looking at the timer, but I am very excited to hear this lecture tonight, simply because this is like the hot topic of 2024. And Brian, are you going to talk about any of the billing and coding aspects of it, or okay, fantastic.
A little
So,
bit. Yeah.
all right, awesome, because I feel like that's obviously this is a condition that isn't new, but I think the billing and coding aspect is why it's kind of been top of mind for a lot of physicians and why it's been on a lot of agendas lately. So I've seen it coming up on a lot of agendas, but this is the first lecture that I get to sit through. So I'm excited to see what's in store.
Yeah. So it's just a few minutes after. I'm going to go ahead and get us started with introductions, and then I'll turn it over to Brian. And while he's presenting, Sarah and I and Nick are going to have our cameras off and our microphones muted, but we are still here. We're listening and available if there's anything you guys need, and we'll pop back on when Brian's done to do some questions and answers. So tonight, our topic is compression therapy and podiatry. Our presenter is Brian Grolo. He has been a lymphedema and wound therapist since 2003 with experience in oncology, lymphedema, primary lymphedema, vascular lymphedema, and lymphatic filariasis.
Very good.
Okay. Throughout his career, Brian has treated extensively in both outpatient and home care settings and managed teams of lymphedema and wound therapists for multiple clinics and home health agencies. He's currently the Director of Education for Medi USA. He also serves on the Medi team for Medical Missions Project to address lymphedema and wound care needs for those with lymphatic filariasis in Haiti, and children with primary lymphedema through Camp Watch Me in North America. Educating clinicians on advanced lymphedema and wound care is a passion of Brian's. So Brian, why don't you go ahead and share your screen and your computer sound, and we will go ahead and get rocking and rolling.
Sounds good. So it's saying I have to install an audio device, which I can't do, so I will just not share that one slide. that's okay.
Okay, no problem. All right, I am going to mute myself and turn off my camera. Go ahead and get started when you're ready.
Thank you so much. I appreciate it. And it's good to be here tonight. As you can see, I've spent some time in lymphedema. That is kind of my world, which led me to a world of lower extremity lymphedema and wound care and home care, kind of the whole gamma. So let's jump into this. Here's what we're going to be talking about tonight. I'm going to introduce you a little bit to Medi and give you a quick background of what we do at Medi. You'll find quickly that our wheelhouse is compression, and not just for lymphedema, but also for vein disease as well, and wound care. We have some products I think that will be key for your day-to-day in the worlds that you're in, with the legs you see and the amount of edema you see, the vein disease that you see. And I want to kind of explain and kind of merge where vein disease and lymphedema kind of come together, and talk a little bit about the coverage that happened this year, 2024. It's been a huge year for lymphedema in my time of practicing in the 20 years. This is just something I've dreamed of, right? To be able to get my patients what they need is unbelievable. So it's a good time to be in lymphedema, that's for sure. So let's jump in, and let's see. Here we go. Since I was already introduced, I'll skip kind of through this. This is just a picture of me and Medi for Help with a person with primary lymphedema here. I'll go through a little bit of what the different types of lymphedema are. But yeah, this is the Medi for Help mission. It's been an amazing experience, both for the filariasis in Haiti, but also for primary lymphedema. Primary lymphedema is a type of lymphedema that is hereditary. You can be born with it. It can be part of development, and it's a lymphatic breakdown in the body that can cause just swelling in limbs. It's mostly limb, but it can be in other places too. Medi, like I said, our wheelhouse is compression. We're a family-owned company based out of Germany, been around for over 75 years, and we've got a mantra that is, I feel better. And it's a commitment, not just to the patient. Like, we want you, like I want, before I worked for Medi, you know, I've been a clinician, and I always want to feel good. I want to feel better, right, about the products that I'm choosing to be a part of the protocols for my patient. And the patient needs to feel good in those products too and feel secure. So that's our mantra at Medi. And we get involved with more than just compression. We've got wound care line. We've got a CEP line, which is our athletic compression line. We've got pneumatic compression pumps. We've got foot supports. We do a whole bunch of different things. So we're involved in a lot. We've got an orthopedic side. We've got a venous health side, and we have a wound care and a lymphedema side, which is where I kind of come in. So let's talk about compression and understanding it, maybe a little bit on a different level than maybe you've dived into before. When you're looking at compression, there can be a lot more to choose from than you think. And typically what I see happen out there when someone's prescribing compression, they're looking at one thing, and that is dosage. Go get 30 to 40 compression socks. These should help you with either your vein disease or this procedure or that swelling that you've got. But what I want to introduce to you tonight is that there's really so much more to choosing compression than just the amount of compression. Certainly that is a big factor, but other things come into play, such as disease, right? And what stage of the disease someone's in. Is it a mild venous disease? Is it severe? Same with lymphedema. Is it mild, moderate, severe? All that plays into how you're going to choose compression. Patient's lifestyle can come into play. What if they can't reach the floor to put compression on? Or what if they don't have the strength in their hands because of arthritis to be able to don the socks? So all that kind of comes into play. There's different types of compression. I'm going to talk to you about inelastic and elastic compression. And I would imagine the majority of what you're used to seeing are compression socks, and those have a lot of elastic in them. And there are other types of compression I think that could be more effective for the patients that we're seeing, and at least the ones that we're going to talk about tonight, especially when it comes to lymphedema. And then, of course, other things, right? There's materials. Every garment's got a different material that they're made from. And that can also affect how that dose or the dosage of that compression plays out on the limbs. So lots can come in to compression. And I've just opened up Pandora's box for you when it comes to compression. And now I've got to go do my job here in the next 30 minutes to close that box for you and help you understand a little bit more of an aspect of how to choose it. So I have 3 essentials of compression that I use to figure out what I need. And those 3 essentials are right here: gradient, dosage, and wall stability. Another word for wall stability would be containment, how well the compression is going to contain the issues going on in the limb. So here we are again. These are the 3 essentials that you're going to be looking at. And what's interesting is you're going to see, I'm going to show this to you shortly, is what happens when you're missing one of these ingredients. Because they are very, very important to how compression is going to react on the limb. So first of all, graduated, or what we call gradient compression. This basically means that when a patient goes to get a pair of compression socks, they need to have graduated compression. That means they have a built-in gradient, meaning that the highest amount of that pressure, if it's a 30 to 40 sock, that 30 to 40 is going to start at the ankle, and 100% of that 30 to 40 starts in the ankle. And as you can see in this image, as it works from distal to proximal up the limb, that pressure slowly reduces. And what you've got is a high pressure at the most distal part and lower pressure as it works up the limb. And this is going to ensure that we're fighting gravity, that we're getting blood flow in the right direction. And theoretically, when it comes to compression, what we're really trying to do is what you see in this picture here, right? We've got the diseased veins, which coincidentally are exactly like the lymphatics. They have the same makeup, and I'll show you that. We want to support these valves in combination with muscle contraction. So that's the idea, and it has to be done through gradient compression. If you look at this picture here, this is more of a thigh high. A lot of times we can be a little bit concerned of how much is too much compression, right? 30 to 40 is a lot of compression. 40 to 50 might be a high amount of compression. But when you look at this, just that ankle area is where that 40 to 50 or that 30 to 40 is going to start. By the time you've gotten to the calf, you're 70% of that number. So you might start at 40, you might be at 30 by the time you're halfway to the calf. So just remember that 30 to 40 is not throughout the whole leg. It's in the most distal part of that garment. Dosage, we've talked a little bit about this already. 30 to 40 seems to be the sweet spot. It's definitely the sweet spot if you've got an open venous leg ulcer. I would argue that more compression is what's needed for somebody with an open venous leg ulcer, with lymphedema even. And I'll show this to you. The only time I kind of come down on compression is if there's arterial disease. And that's, patients with diabetes might force us to lower the amount of compression. But if that's not a factor, I'm going for high amounts of compression, because that's really what's indicated for the disease process, right? That's one of the first things we talked about in choosing compression. What's the disease, and how advanced is that disease? And that's going to set the stage for how much compression to use. So the other thing is containment. You heard me say wall stability, AKA containment. And what that basically means is how strong is the materials and the fabrics of the garments that you're using going to work against the disease that you're combating. I got this picture of a dam here and all the body of water that it's holding back. And I kind of just pretend like that body of water is edema. And I wish that we could make garments out of concrete walls, but we don't. Instead, we make them out of inelastic materials. So you've got elastic socks, which you probably know well, but let me introduce you, if you don't know already, about inelastic materials. Inelastic compression is the best way to get the response of the venous and the lymphatic system when we're talking about reducing swelling and increasing venous return. You may have seen patients that have a lot of edema, and they've gone into an elastic sock, and what happens? this happens, right? This is a perfectly good garment, 30 to 40, gradient compression on the wrong patient, right? There's too much edema. In other words, we're missing an ingredient here. Maybe you can figure out which one it is. This is a better choice for this patient. It's still an elastic garment, but it's what we call a flat knit, and it's custom made for this patient. It's a very different type of material. It's more stout. And because of the fabric change for this patient, we have a dramatically different outcome. And this is what we get. Like when we miss one of the ingredients, one of the essentials, we forget to look at what the materials of our compression are made from. This is what you get. Let's pretend like we did have the right material here, but we dropped the dosage down to 15 to 20. I think we'd see something similar here. We'd see a limb that wasn't well contained. We've got to have all of these essentials. So when you're picking compression, you don't remember anything tonight, remember those 3 essentials of compression. Here's elastic versus inelastic. And what I want to briefly show you about this is their reaction to muscle contraction, because it's significant. If you look at the 2 pressures of calf muscle pumps, we've got the resting and the working pressure when the muscle contracts, when the muscle doesn't contract. And if you think of a compression sock, an elastic compression sock, and your limb is at rest, the muscle is not contracting, you've got the elastic fibers of that garment that are recoiling on your limb. So what you get is a high resting pressure. When your limb is at rest, that garment is working. But when your muscle contracts, well, then so does the garment. It just kind of goes with the flow. What happens is you don't get a change in pressure. And the elastic socks just kind of go with the flow. They give you the compression when you don't want it. We actually don't want that much pressure when the muscle is resting. We want that pressure when the muscle is contracting. So now think about something that doesn't have elastic in it. All of a sudden, when the muscle is at rest, because there's no elastic, there's minimal recoil, so you have a low resting pressure. And then when the muscle contracts, this short stretch, this inelastic wall doesn't budge much, and it spikes the pressure in the venous system and the lymphatic system. Combine that with gradient compression, and you've got movement of edema and blood flow from distal to proximal. So the more, I always encourage, the later the disease process, the more you've got to switch to something with more containment. And I would say the more you go towards inelastic compression, the better your patients are going to do. So briefly, let's look at the venous and the lymphatic system. I think we all know what arteries and veins do quite well. What I like to point out, though, is how intertwined this lymphatic system is with the venous and arterial system, especially the venous system. Yes, the lymphatic system is its own system, set apart, but it is working in sync with the venous system. Without the lymphatic system, the venous system would fail. In fact, we used to think that veins took up 90% of the waste, and we now know that lymphatic system takes up 100% of that. So when you've got swelling and edema in that limb, you have a lymphatic component also to that. Here's a good look at normal veins. And what I've done is I've put what we call lymphangions. Those are lymphatic vessels. Look at how similar they are. Yes, they're different, but you can see the bicuspid valves in the veins that are also in the lymphangions, and they move the same way. Look at the muscle contraction. Look at the interstitial tissue, where the lymphangions are, where the veins are. They have very similar makeups, and they respond the same to compression. So in a sense, the same compression you use on veins can be the same you use on lymphedema, but I would say flip that around. The compression that you use on lymphedema can be the same that you use on the venous system. Here's a good look at what muscle contraction does and the power of it in response to the bicuspid valves and movement of blood. I think we all are pretty familiar with that. The advancement of vein disease, again, nothing new to anyone here, but lots of different progressions of vein disease. You've got your healthy, normal veins here. You've got your diseased veins here. And what do we need to combat this? compression is a big turn to for something like this and can really help, whether it's in the deep system or whether it's in the superficial system. The progression of vein disease, you know, this is basically the staging of vein disease, right? You can start with really C0, which there might be some underlying disease that just hasn't made itself present yet. And as it progresses through spider veins, varicose veins, then you get edema, hemosiderin staining, lipodermatosclerosis, all the way to an open wound. The advancement of vein disease should also reflect how much compression is being used, right? So if you've got C1, yeah, sure, 20 to 30 might be a good C2, 20, 30 might be good as well. As soon as you're at C3, my suggestion is you should already be at 30 to 40. Somebody with an open venous leg ulcer, really 30 to 40 is the sweet spot, but I'd say that's the minimum. If they don't have arterial disease holding you back from using a high level of compression, the higher the disease, the more advanced the disease, the more compression dosage is what's needed. And that's the same for lymphedema as well. Here's lymphedema, upper and lower extremity. It's the abnormal accumulation of protein-rich fluid. So lymphatic swelling isn't necessarily liquidy. It's a great word, right? It's a scientific word, I hope. It's very, it's high in protein. It can be very fibrous feeling. It can be very dense and woody. It can be non-pitting, as opposed to regular edema, say from heart failure, that's very putty. And it will displace very easily. Lymphedema doesn't necessarily do that. Whoops, I just went the wrong way. So let me show you about two different causes of lymphedema. Dynamic insufficiency is really the type of lymphedema that you're seeing mostly of. It's derived from vascular disease. And it's a simple math equation of your lymphatic system has a certain amount of fluid that it can handle on a day-to-day basis. And then it's got an overflow that it can also handle. In fact, it can handle up to 10 times its normal load. And I want you to take a look at what's happening, not in the road, but in the river, right? Because this is your lymph flow. These are your veins, right? What happens when the river backs up, right? The river can only hold so much. And so what happens is things get backed up. This is not an obstruction. This is not from obstruction. It's just from too much. It's from an overload. And eventually, that overload will lead to backup in the lymphatic system, and it will become stasis in the same way that the veins do. And then you get that backup. So really and truly, what's needed here is a little bit of compression to help boost this out of here. But this doesn't have to do with a lot of the typical reasons that you get lymphedema. A lot of people know lymphedema through what's called mechanical insufficiency, or what we know as oncology lymphedema. You've got cars going down the road, it's an open freeway, but all of a sudden, lymph nodes are removed, right? And that freeway is now down to one lane. Of course, your lymphatic system is going to back up and it's going to cause lymphedema. This can happen from scar tissue. This can happen from primary lymphedema, which you heard me before, and filariasis as well. This is actually an obstruction of the lymphatic system itself. This is not an obstruction. It's simply an overload, probably because vein disease happened first, and that caused a backup, which led to a backup over time in the lymphatic system. A little bit deeper into it, you can have a mixture of both. I've seen plenty of oncology lymphedema patients that also have vein disease, so they have a little bit of a two-cause reason going on for their lymphedema. Lymphedema is broken down into two types. Primary lymphedema, which you heard me talk a little bit about. It's hereditary and can happen during development. It can be congenital. You can be born with it. Different eras of the developmental stage of life. And this can be just from a lack of lymphatics that developed, or improper development of those lymphatics, enlarged lymphatics, different reasons for that. A secondary lymphedema from oncology. This is because something happened to the lymphatic system, whether it was lymph nodes removed, scar tissue, vein disease happened, and it led to lymphedema. Obesity can lead to lymphedema as well. This is called secondary lymphedema. It happened because something else happened first. There's different stages of lymphedema. I will briefly go through this for the upper and the lower. But just like the vein disease stages, the SEEP scale, the lymphatic system has its own scale. Stage 0 for the arms and legs is when there's some underlying disease, it just hasn't made itself present yet. Get to stage 1, and you can start to see it, but it goes down at night, comes back during the day, starts to play a little bit of ping pong, going back and forth. It's still reversible. Stage 0 and stage 1 are your chance to get compression on these people now because it's still reversible. Stage 2 is an irreversible stage, and it's there to stay. It's been around a while. The damage is improvable, but it's not necessarily reversible. Stage 3 is the most advanced stage of lymphedema. So yes, there are 4 stages. The first stage is a stage 0. And it goes up to stage 3. Stage 3 is very severe, decreased mobility, high skin folds, and deformities can happen. So it can be a really big impact on their quality of life in the negative way. Here's a couple different looks at what I would suggest for compression, right? Stage 0 stage, the higher the disease, the more advanced the disease, the more compression you need. Stage 3, yeah, I would be putting that patient at 50 to 60. Again, as long as there's no arterial component, definitely. Stage 2, 30 to 40, 40 to 50, definitely. If it's possible, I want that on. It's what the patient actually needs. So let's look at some different products. There's just different categories. Our Mediven, our elastic compression line, elastic stockings are great. We've talked a little bit about those today. Sure, they're not going to be, you saw them in the wrong setting, right? Elastic stocking on a lymphedema leg. That's just not what they're made for. They're made for preventative reasons. They're made for early stage. They're low profile. People like them because you can wear these. I wear them all the time. People would never know that I'm wearing compression socks. They look like normal socks. So they have a really good benefit in the sense that they are low profile. They look really good. We have a flat knit line, which you see here in the second one, and you saw a picture of that. That was my solution for the patient that was in the wrong garments. Flat knit is an elastic type of garment with a much more robust material. What I really want to talk to you about is the Circade line. This is our inelastic line. This is what we talked about, inelastic compression having the best effect on your venous and lymphatic system. It's awesome because it's adjustable, so you can fit in a size range. Think about your patients donning and doffing, much easier. I've had a tremendous amount of success with these products in the home care space and in the wound care space. What you're looking at to the right are nighttime garments. We use these in lymphedema patients because, like you heard me say, it's a high protein content. So sometimes we have to go after the tissue. We have to soften up that tissue enough so that it can move through the body and make its way back through the lymphatic system. And we use products like this. They're foam-based products. The Mediven Forte is our strongest elastic, what we call circular knit garment. And so this is a really good garment for someone with stage 1 lymphedema. I would use this for somebody with C3 vein disease, maybe C4 as well, even with someone with hemocyanin. If there's no swelling, this is a great choice of a garment. But if they can't get it on, then I'm going to move into something like that, an elastic adjustable wrap. Again, this is a look at flat knit garments. You can see the seam down the side of these garments. They're made flat and then sewn together according to the size of the measurements that are given by the fitters and people that measure. So Circade is a great solution for a lot of our patients. Like I was saying earlier, it's a great solution for lymphedema. There's a big range that people can fit into and easier to put on. So Circade stands for Circulation Aid. They've been around for a good while. What's really cool about them is their measurable compression. I'm going to try and show this to you just shortly. You can actually set these to a compression level. You can set them for 20 to 30, 30 to 40, or 40 to 50. Easy to don and doff. They're Velcro. They enclose by Velcro. The adjustability means that patients can kind of tighten them if the swelling goes down or if it moved out of place. They can keep good compression on their limb at all times through the weekend, right? They're not, If you're bandaging a patient, right, they come back a week later, the bandage is down to their ankle. You know, they have the ability to readjust these and keep good compression on their limbs. Independence is an issue, right? If you have patients that want to be involved in their own care, or you're trying to discharge them and they're trying to provide them a solution of like, look, we got your wound healed, or you've got vein disease, you've got to wear compression. I see that you can't get normal compression socks on, but we've got to get you in compression. This would be a great option. These can also be worn at nighttime because they're inelastic. That makes them safe for day and nighttime use. The other garments, the elastic compression, those are daytime only. So that's another thing that you can utilize these for, is compression around the clock as needed. So here's the video. I can't share audio, but I'm going to play the video anyway and kind of talk through it for you.
Apply the Circade compressive undersock by pulling it over your foot and up the leg to the knee. Some find it easier to apply by sliding your hand into the sock and turning it inside out at the
So this sock actually has compression in the foot. There's no compression in the leg, but there is compression in the foot.
ankle before sliding onto the foot. Make sure there are no wrinkles in the Circade compressive undersock. Align the Circade juxtalight just over the ankle bone and just below the knee crease. The black side of the material should face the skin. Unroll the top two bands and loosely secure them to the outside of the garment to anchor the garment in place. This enables you to easily raise or lower the garment for correct positioning. Unroll the bottom two bands and secure the bottom bands to the outside of the legging to a firm and comfortable compression level. While holding the second band, detach the next band and continue this process with the other bands going up the leg. Ensure that the bands are placed in an alternating order. The garment should lay flat and wrinkle-free against the leg.
So as you can see, the straps just kind of go across. They call what we call a juxtapose, and the Velcro just fastens directly to the garment. And you can tighten those straps as needed. I'm going to show you one more thing, and then we'll
Adjust each band to a firm and comfortable compression. Once all the bands are secured, inspect the garment for any gaps or creases. Adjust lines on the
So
bottom
this is the
band.
built-in pressure system.
Note where the second BPS line lines up with the card's compression ranges. In this case,
And what you're going to look at here is the distance between these two marks on the garment. When you stretch the strap, it stretches the distance between these two marks, and you're aligning them to these marks. So right here, we've got a nice 30 to 40 set strap, and you're going to set each of those straps.
the patient needs 20 to 30 millimeters of mercury.
You'll see here
If more compression is needed,
that strap doesn't
tighten the
make
band
enough
until the
distance.
correct
You
compression
stretch it
range
out,
is achieved.
and you set it to 20 to 30. That's the strap we're going to play.
If less compression
So this is the Juxtalight, the Circade Juxtalight, and it comes in two forms, the Juxtalight Standard and the Juxtalight HD. The HD, there's only really one difference between these two, and that HD is twice as thick as the Standard. I use the HD mostly just because I deal with edema a lot, and I need that extra wall stability or containment for lymphedematous patients. If I've got someone with vein disease that doesn't have edema but has struggles to get their garment on, I'll use the Standard Juxtalight. If they've got any edema at all, I will use the HD. It comes in 16 different sizes, so there's a lot to choose from there. Here's a couple different other products. This is a Juxtalight HD. This is a Juxtafit. Notice how more straps are there versus the Juxtalight. So more straps equals more containment. This is a full leg setup. And this is a Juxtafit Premium. These two garments here are very similar. There's only one difference in that this one has built-in landing strips, which are good for patients to visually know where the Velcro goes, but it also creates longevity in that garment. So that garment will last, it's warranted for a year. because of that. Here's nighttime compression, which I talked to you a little bit about. These are foam-based products. They come in they full leg and lower leg, and they have chip foam in them, and that causes high and low pressures throughout the limb, which helps soften the tissue texture. They wear this at night only to soften up that tissue so that when they go into their daytime compression, that fluid can move throughout, and it's really a process of time. They do this every day for their lymphedema, and over time it softens and reduces. So wrapping this up, I want to just talk to you briefly about the Lymphedema Treatment Act, which I know a lot of you are eager to know about. You all probably are very familiar with how compression is reimbursed for vein disease, right? If you've got an open venous leg ulcer, compression is covered, but you've got to have that documentation of that open venous leg ulcer. It's got to be an amount of 30 to 40 or more, proof of debridement. So there's a whole set of documentation that you need and criteria that is needed for somebody to get compression for an open venous leg ulcer. If that venous leg ulcer is not open, that coverage goes away. So this is coverage that only happens if in the presence of an open venous leg ulcer. For lymphedema, it's different. If you have a diagnosis of lymphedema, which in most cases in your world is I-89.0, that's a lymphedema not elsewhere classified, you are eligible for lymphedema coverage under Medicare. There are other diagnosis codes that you can see up here. These are the only 4 that have this coverage. But once again, I think the majority of what you're going to see is I-89.0. And if you look back to some of what I said earlier, vein disease that leads to edema or lymphedema, if you've got edema, you have a lymphatic component. So if you're worried about whether or not there's a lymphedema there, remember the stages of lymphedema. Stage 0, stage 1, just like vein disease. There might not be something present visibly, but there could be underlying disease. So that's food for thought for you. There is coverage for these patients under these diagnosis codes under Medicare. Bandages are covered. I won't talk to you too much about bandages, but lymphedema bandages are covered. Lower extremity garments are covered. These are ready to wear. So if you need somebody with an 18 to 30, in other words, if you needed to do a 20 to 30 garment, 30 to 40 garment, or 40 plus, these compression socks are covered for patients for custom and for ready to wear. Same with upper extremity too. And it can be knee high, it can be thigh high, it can be pantyhose styles. It all goes in line to what their diagnosis and where the lymphedema is. If it's below the knee, they're eligible for a knee high. If they've got full limb lymphedema, they're eligible for a thigh high. It all aligns with itself, and that should be present in the documentation. But coverage exists for Medicare patients for these different levels of compression with those diagnoses that I showed you. Wraps like the Circade Juxtalite, those are ready to wear. Those don't have custom codes, but the majority of your patients should be able to fit into those, and they're eligible for those as well. So somebody with an open venous leg ulcer, the venous leg ulcer closed, but they have the diagnosis of lymphedema, they're good to go. They have eligibility to go after those products. Same with nighttime compression, the chip foam, those are also eligible under the Lymphedema Treatment Act for patients with that diagnosis. Now let me show you what they can get. Let's just skip over the bandage section for now and look at the garments. Maintenance garments, so daytime garments. They can get 3 sets. That means the elastic socks. They're eligible for 3 sets every 6 months. They're also eligible for the inelastic adjustable compression wraps, and they're able to mix and match. They can get 1 of the Juxtalite HDs, and they can get 2 of the compression socks. So there is that ability to kind of mix and match, but they have ability to get 3 of these every 6 months. Nighttime garments are basically one set a year. They basically say, yeah, one annually, 2 sets every 2 years. So there is good coverage for these. It's all done by body part, foot, toes, lower leg, upper leg, full leg. So yes, it's pretty good coverage, I would say, because all my career, patients have been purchasing this stuff out of pocket and never getting enough of what they need, and now they have that stuff available. So, yeah. So this really concludes my my talk here today. I'm sure there's some questions out there, but happy to answer those. And yeah, that's it. Thank you so much.
Awesome. Thank you very much, Brian. Um, Nick, I see you're hopping on here. That last slide that was shown on the screen talked about a toolkit that SureFit offers. Do you guys have, like, what kind of resources do you guys have to support doctors who are using these kinds of products?
Yeah, absolutely. So, in addition to samples of the product as well as the measuring kits and tools, we carry the full Medi line. So, if there's any products in specific you're interested in getting more information on, certainly please fill out a form or the survey after the webinar, and we can get those to you. One question I had, and Brian, if you don't have it, I do have it up, but thought it'd be helpful to tell everybody the average reimbursement with Medicare on like the per unit basis for the, say, the Juxtalite HD with a liner.
Yeah, I actually don't know that stuff.
That's
All
that's
about the
fair. So
product. Don't know pretty much.
it's 184.52. And just to give people kind of an idea of the cost wise on these units, they're typically around for one garment in the liner, it's typically in the $60 range. So with a reimbursement at 184.52 and you're doing 3 of these every 6 months, obviously it's pretty impactful from a practice standpoint. Obviously it's great patient care, but definitely impactful, especially as offices I tend to hear are looking for more treatment options outside of just grafts, which obviously have taken a bit of a turn here. So that's one thing I did want to call out as well.
I had a quick question, Brian, and I apologize if this is, the one slide was about 3 slides ago that just kind of confused me a little bit in terms of, I guess what the limit is. So you said that in order to have the coating, there would have to be the ulcer, but then I guess the simplest way to put the question is, does there have to be an open wound? Like, is,
No.
okay, so that's what I thought. So I guess, what is the limit? So this may be the dumbest question on the face of the earth, and I'm really sorry. So like, would an acute sports injury that creates edema, is that in any realm here, or it has nothing to do with it?
It's not, because it wouldn't fall under the diagnosis of lymphedema. Lymphedema typically gets diagnosed by clinical findings, and you typically, when edema sits around, they basically, when edema has been 4 weeks or more, is really the
So it
start.
needs to be chronic. It can't just be an acute situation.
Correct. It's a chronic,
Okay.
it's gotta be for valid reason. Like if you say, if someone's documentation was to say, yeah, we diagnosed this patient with lymphedema after a soccer game, Medicare would be like, yeah, that's probably not gonna, they're looking at not just the diagnosis code, but they're looking at what's backing up that. If you
Mhm.
said patients had chronic venous insufficiency times a history of times 5 years, hemosiderin staining, and now is present with lymphedema, I-89.0, boom, like you've got a story that makes sense.
So the
So
underlying issue is critical.
it is, yeah. If you diagnose someone with post-mastectomy lymphedema, someone should easily be able to go and find that they have breast cancer. You know what I mean? Like that stuff, that paper trail is always there.
What about post-surgical that is like a long, an extended healing process?
It happens like knee replacements sometimes have caused that, but usually it's not just a knee replacement that hasn't healed. Usually there's still like some vein disease underlying too. But I have seen it happen where people get a diagnosis of lymphedema for swelling that's around for multiple months, just hasn't gone away. And I would
Because
say
of the
that,
surgery, like the underlying reason would be the surgery itself.
yep, and that goes back to trauma, scar tissue.
Okay.
You can follow that history as well, right down to the very end, and it makes sense.
Got it.
Ankle, there are plenty of ankle injuries with surgeries that have scar tissue that are adhered to the bone that do cause lymphedema. I have seen that, but
Mhm.
that's very chronic.
Got it.
So just as a
Um,
reminder to anyone online with us tonight, if you have any questions for Brian or for Nick, you can type them into the Q&A box that's found along the bottom of your screen, and we'll get those answered for you.
What are your thoughts, Brian, on obviously I know we're talking about compression stockings. But what are your thoughts on combination therapy with something, well, you can tell like throw anything out there in terms of combination therapy, but like laser therapy. Is this something that is in the I know it's not billable, but does that play a role in any of this?
From my understanding, the therapies that go in conjunction with this are, well, I'm a lymphedema therapist, so what we call complete decongestive therapy is a type of therapy, and it's done by a physical or occupational therapist, and it's specific to lymphedema. There are other therapies that can be beneficial. People do, trying to think some of the modalities that people do. Pneumatic compression, but pneumatic compression is really more of a maintenance tool. Laser therapy, not so much. Anodyne therapy, not so much. It's really down to compression and what we call manual lymph drainage. There are a couple other modalities that can be done, but they're not typical fluidotherapy or anything like that are seen in therapy. A lot of people used to do retrograde massage.
I was just gonna ask about massage. Yeah.
The massage is still a treatment. It's just not, it's not the most effective.
Acupuncture.
Acupuncture is not, there are some, yeah, acupuncture does more damage to the lymphatic, like as far as lymphatics go, it can be very dangerous because the last thing you want on a lymphadematous limb is open areas that can be susceptible to infection. So acupuncture does not
Got it.
bode well for lymphedema.
We
Okay.
do have a question or a couple questions that have come in. Can a patient with a pump get the garments covered?
Yes, two different, what am I trying to say? Pocketbooks, I guess. Your pneumatic compression is billed very differently than your lymphedema garments. And the criteria is also different for pneumatic compression pump. So a pneumatic compression pump requires a diagnosis of lymphedema, but it requires 4 weeks conservative therapy, meaning that they've got to be in compression for a certain amount of time. And after they've been in compression and they've done exercise, they still have to show that they still have swelling. After they've done all those therapies, they still have swelling, and therefore it shows the Medicare and the insurance companies that, okay, you clearly have lymphedema. We tried to address it. Goes back to your ankle swelling question. You're not going to get a lymphedema garment without trying other things first. So yes, you can get a pneumatic compression pump in conjunction with these products as well.
Another question is, do you ever use ACE wrap or an Una boot?
ACE wraps, sorry to say this, but ACE wraps are a curse word for a lymphedema therapist because to go back to what I talked about, they have so much elastic, right? Everything in the lymphedema world has to do with short stretch and inelastic compression. And the studies that have been done on lymphedema have been shown to have the same impact on the venous system. So we've learned a lot that inelastic short stretch compression is the most impactful for venous and lymphatic disease. The question about an Una boot is that, yes, an Una boot is inelastic, but they have zero stretch, and they're made to be pulled too tightly and not able to kind of control the amount of compression going on. I do use Una boots in the wound care world, but I use them in such a way that I'm not putting compression on with the Una boot. I want the zinc against the skin. I want the skin care from the Una boot, not the compression. So I will do an Una boot directly on the skin and pleat it so that there's no compression in it, and then put like a Juxtalite on top of that so that the compression is coming from the Juxtalite, not the Una boot. The Una
How do you
boot,
know the limit between improving circulation versus cutting it off?
that's the thing about Una boots, is they can be painful to a patient. They can cut circulation off. Inelastic is safer. The patient that you saw that I showed you earlier that had that really bad looking garment on the leg, clearly they had a tourniquet going on, and that was uncomfortable, painful, and potentially dangerous. But you can get a lot of feedback from your patients. To me, it's just a matter of knowing what your ABI is. If you know what your ABI or TBI is, then you can base your levels of compression that way if you're worried about that. And ABI is a big deal in the wound care space. Everybody with an open wound should have an ABI. I would argue everyone in the lymphedema world should as well, but we haven't gotten that far yet.
I'm sorry, I know, like, I'm like the question. I've been really excited about this lecture tonight. So, I don't know, this is, 2024, the LTA, it's not like swelling. It's not like this has existed forever. Why not? Like, what happened? Because my confusion is, I mean, DFUs, I feel like, cause more money in the healthcare system with amputations than swelling. Am I like, I don't understand why this happened. Do you have any backstory here?
Why? What happened? The coverage for lymphedema?
Yeah, I just feel like, why this act versus something else that's maybe like more specific to a DFU? Like it, and maybe that's not the correct comparison, but I guess what was the straw that broke the camel's back to focus on this specific issue?
Right. Well, the issue was that this wasn't something, the way this got into action was through a mom who had a child with primary lymphedema, a very different type of lymphedema. And she fought for 14 years to get this bill passed, to get coverage for lymphedema, because she, who had a child that she needed resources for, and those resources weren't available. Couple that with oncology world, these patients were getting lymph nodes removed, radiation, and they also needed interventions. And the intervention of what they need is compression. Also, it's, lymphedema therapy as well. But these people just were, and also the diagnosis of lymphedema is a lifetime. It's a forever diagnosis. It doesn't go away. You can only manage it. So that's another factor that makes it different than a lot of other diagnoses. So you put all that together, you've got a pretty good story and argument to go to Congress with. The cardiovascular lymphedema just happens to fall into that bucket because it also is a diagnosis of lymphedema. But I think the lifetime diagnosis is probably the biggest part of it, and the fact that you cannot control it, manage it, and have a quality of life without compression. It's impossible. I don't know if that answers your question, but
No, it does. And after I asked the question, I was just like, well, duh, Sarah, it's not like DFUs aren't covered by Medicare and things like that. So it is, I guess I just never really realized that compression, like, it wasn't covered at all. Like, what was the limit?
No, well, some of it was covered by insurance companies, but Medicare covered the treatment of it, which was huge. That wasn't always a factor either. So we got we have treatment covered years ago, but that was the treatment. And that lasts 2 to 8 weeks. The patient has it for the lifetime. And like I said, the medicine for lymphedema is compression. Like your medicine is covered under insurance and under Medicare that you take for whatever disease.
When you say medicine, you mean like an oral,
No,
or are you saying like for
I am.
doctors?
I'm saying that like if you have heart failure, you're going to take oral medicine. There's no oral medicine for lymphedema. The medicine is compression.
And from a
So,
healthcare cost standpoint, Sarah, I'd say it's similar to why diabetic shoes are covered to avoid DFUs, and that long term, it's much cheaper to the system to cover
And that's
preventative
what I was
care and
curious about,
maintenance
like what,
Big
versus lymphedema going
right,
out of control and leading to hospitalization,
exactly.
amputation, other stuff.
The big risk of lymphedema is cellulitis. Cellulitis happens. It's a very scary infection, often mistaken
Because
for
of non-healing wounds.
no, because there's so much edema in the tissue that even if they get a mosquito bite, um, the body's ability, the blood's ability to get to the skin, because of that layer of edema, the bacteria builds up underneath the skin and it can lead to an infection that your body can't even get to fighting. Like you prescribe oral antibiotics, but still the edema is blocking the ability for even the oral antibiotic to get to the skin to get it taken care of. So they end up in the hospital nearly on the deathbed, and it's very expensive. So the idea is that you're preventing hospitalization.
Brian, so we're talking about, wound care and potentially draining limbs. What is the recommended care for these products?
Well, all of them can be laundered. The Juxtalite can be laundered, but I would recommend laying it flat to dry. But everything can be laundered. If you've got drainage and exudate, I recommend using appropriate absorptive dressings, particularly super absorptive dressings that will prevent the exudate from striking through onto the compression, but it happens just the same. If you've got somebody that has so much exudate that you have to change that dressing every day, I would recommend that maybe they're not quite ready for these products yet. You've got to get that drainage under control before going into these, because these are in some ways more maintenance than they are treatment. Although you can use the Juxtalite for treatment, but you don't want to have that exudate under control.
Dr. Barbara Hirsch asked, how long has this been covered by Medicare? And I know we kind of touched on that, but
The coverage for lymphedema started in January of this year.
okay.
Are there resources for individuals who are unable, that live alone and are unable to don these products on their own?
Unfortunately, there aren't. We rely on caregivers and we rely on family members to help. That's why the Juxtalite's so important, is because a lot of people can't get them on, but there are patients that can't get them on too. And so a lot goes into the therapy for teaching how to don and doff. And you're teaching a caregiver. That's part of therapy. Sometimes that's like a few therapy sessions. It's like, okay, I need you to bring your spouse in or your son or daughter in so I can teach them how to do this. But as far as someone going to the house to do this stuff for people, no.
I was gonna say, so if like you're single and like 400 pounds, you're just kind of SOL.
It's tough. I know that there are some home care agencies out there that might dabble with doing these types of things, but they are so far and few between. I couldn't even tell you one that does it. It's a gap for sure. But then again, it's a gap because it would be an out-of-pocket expense for a patient, and like who can afford that? It's crazy.
What garment would you recommend for someone who had liposuction for their lymphedema and now they need a compression garment for post-op and for the future?
That would absolutely be this garment here. This is a flat neck, custom made garment. This is a very specialized garment, needs measurements for many different areas of the limb. But this is exactly what all of the people that undergo microsurgery for lymphedema and liposuction as well. All the specialists that I work with, this is the product that they use for that.
Okay,
I wouldn't
interesting.
mess around with anything else. Even if a garment, a ready-to-wear garment could fit that patient, I would make sure it's custom. You want that thing to be made for their limb, nobody else's.
Right. Right. And then we had another question come in. Did you discuss superficial massage as a part of a treatment? I know we kind of spent a second on that, but could you talk about that?
Superficial massage is basically what we call in our therapy as a lymphedema therapist, it's called manual lymphatic drainage or manual lymph drainage. It is a very superficial massage and it's made to stimulate the lymphatic system. And you promote the movement of those lymphatics toward the lymph nodes. So you've got lymph nodes in your neck, under your arm, in your groin, all over your abdomen. And the idea is they all have certain drainage areas that they lead to. And the superficial massage or the manual lymph drainage, what we call MLD, is the type of massage that we do to stimulate the lymphatic system and help decongest that. It's something that we do in therapy before we put compression on. So we do the manual lymph drainage and then we compress.
This is a weird, when you say drainage, like, what do you
Not
mean?
physical.
Drainage
Not
where?
physically like.
What's coming
like-
out?
No, drainage meaning that it's stimulated to reabsorb into their body, into the lymphatic system.
So it's like a recycling system.
Yep, basically it
Okay.
goes to your lymphatic system brings it back to your blood brings it to your kidneys filter it out and becomes urine.
Oh, okay. That's what I wanted to know.
That's the
I,
drainage.
that's gross. But I was like, are we talking about sweat or urine? Because I just wanted, I had to like figure that out. Okay. Thank you.
So Nick, if somebody wants to try samples or has questions about, the product, cost, ordering, that kind of thing, what's the best way for them to get in touch with you?
Absolutely. I will put my email in the chat as one way, or you can certainly fill out, the post-webinar survey with information, or you can go to surefitlab.com as well as podiatrymeetings.com and look at our online booth, but I will drop it into the chat as well.
Awesome. Thank you. And I will send out an email this week to everyone who attended and also registered and wasn't able to attend, a link to more information from SureFit and how to complete a form if you're interested in trying a sample or anything like that. Do we have any other questions before we say goodnight on this Monday evening?
And if you could drop that in the chat for everybody, it doesn't look as though I think it just went to the
Sure.
host and
Yep.
panelists.
You got it.
Oh, yeah. I think everyone's spent.
All right, I just put Nick's email address in the chat. So if you have any questions or special requests or anything, you can just email him directly. Like I said, we will send out an email later this week with some more information. And Nick, where are you on the road? Where can we see you SureFit next?
We will be at Top Practices. We will be at the Balance Health Summit. We will be in Boston at Region 1. We'll be at ACFAB, the pediatric conference.
Awesome.
We'll be all over on the road show this fall. So if we don't see you at a local state show, we'll likely see you at a regional or a specialty show. Or you can certainly reach out and we can schedule a one-on-one webinar or schedule an office visit if it makes sense.
Cool. And we just got a question in wondering if this presentation was recorded. It is, and we should have this up in the next 48 to 72 hours at podiatrymeetings.com at our webinars section under Academy recordings. So you can access it there, share with your colleagues, And obviously for your own benefit, but those will be any practice partner academy that we've done in the last several years is accessible there.
Yeah. Thank you guys for joining us tonight. Thanks to all of our attendees. Thank you, Nick and Brian, for being here and for sharing your expertise with us. And we hope to talk to you all soon.
Thank you. Appreciate it.
Thank you.
Awesome. We've got another practice partner academy in a couple of weeks with Dr. Ritchie. Keep your eyes peeled, and we'll talk to you soon.
Good night, everyone.
Good night.